with the CRMO. So that's how it can present with a lot of sclerosis, just like this over here. And another patient, 15-year-old, persisting pain in the left knee. Again, you see this sclerosis, and that was also similar like the other patient, was diagnosed as CRMO. And biopsy was done of this area, but it turned out to be nothing. It was normal, and that's the way of really, CRMO is a diagnosis of exclusion. So as long as there's no infection or tumor there, then CRMO is likely. But for imaging wise, this is quite classic for CRMO. You get sclerosis on the X-ray, and really it's a non-infiltrative kind of a process. There's no soft tissue, there's no peripheral reaction, and you get this abnormal appearance on both CT scan, the sclerosis, and the edema in the proximal tibia. And a 13-year-old male came with limping, and it's very subtle, and you can see this elevation of the along the iliopectineal line, and the MRI was done, which showed quite significant enhancement of hyperintensity and also enhancement of the post-contrast sequences. Well, this patient actually had two lesions. So we were thinking about Ewing sarcoma initially, but it was very unusual to have two areas. So CRMO was given as a differential, and that's what it turned out to be. He came back after a year with the kyphosis and had quite a number of bones involved. And you don't only get vertebral planar with LCH, you can even get it with CRMO, and that's what this turned out to be. 70-year-old female with limp on left side and thigh pain. And again, the x-rays were not very useful. Both pelvis and knee x-rays were done. And then we saw this signal change in the MRI in two different areas. So again, his bloods were not very abnormal, and we gave a differential of CRMO, and that's what it actually turned out to be. So you end up getting quite a bit of CRMO where we are for some unusual reason, although it's not something which is very common where we get to see it quite a bit. A 9-year-old male came with pain and swelling in the distal radius. So this is probably my only case of the upper limb. And he had a previous fracture 3 to 4 years back. The same thing had happened in the lower limb as well. The fracture was there, it all healed, as you can see on this x-ray. And but now he came back with some pain and swelling, and there was a lucency there, a new lucency that developed. MRI was done, and that showed some enhancement in the periphery and non-enhancing area in the middle. And then he was, they went in, aspirated that, found out it was infection and abscess that had developed in the previous fracture site. But not always. It has to be. Sometimes you can get these post-fracture healed, like this 10-year-old male that came in who had this fracture, and then it got healed. And while it was healing, this lucency developed, and then that persisted for a few days. But his bloods were not very abnormal, and we just followed it up over time, and it healed eventually. So that was just a lucency at the fracture site. So that's really it. You can get a spectrum of different infections, and that is really what we treat as emergency in our center. Other than that, fractures and tumors and things like this, you have a few days to work it out and figure out how to treat those patients and what the diagnoses are. But with our infections, it's something that they really want to go in, because once the child becomes septic, then they really need to make sure that the child doesn't get septic by draining that pus out. And then I showed you a few different scenarios where we get a similar limping child, and sometimes their bloods can be elevated, but then it shows that you just have to be careful about those different spectrums as well. Thank you.
Thank you so much, Dr. Nader, for this wonderful talk. I would like you to unshare your screen so that we can run a short poll to see what does our attendees think of our questions and what have they gained from this wonderful talk. So the poll is now open. I'd expect a good response from our attendees. So we'll just let it run for 10 other seconds. Okay, so now let's see the results. Okay, so wonderful. On to the second question. So 10 more seconds.
That's very interesting.
Yes, the mixed responses. Okay, so end. Time to share the results. So these are the final results. Would you like to make a comment on that?
Yeah, sure. I mean, with this one actually, so yeah, non-enhancing area in the marrow. So not always marrow signal changes, which can be a bit of edema or a bit of enhancement, will confirm osteomyelitis. So we don't. So those cases where I showed you about the heterogeneous appearance, and then the contrast was given to show you those areas in that heterogeneous pattern, which is non-enhancing. Those are the foci of pus, which our surgeons will go in to try to aspirate. And the other one, sorry, yeah, the other one was, I think most people were right, that you really want to see joint effusion and any abnormal appearance in the marrow, and those things are always things that you have to pick up to know that they are really truly infection or septic arthritis, and treat those kids accordingly.
Yes, sir. Thank you very much. So just before starting the pre-recorded lecture by Dr. Wasim, we would like to run a short poll for Dr. Wasim's talk to see what do our audience thinks prior to his talk and see what they have gained from his talk. So we'll be starting a short quiz prior to Dr. Wasim's talk. So question number one, I hope it's visible to all our audience. So we'll be closing it in 30 seconds. So when in doubt, how to differentiate fracture from synchondrosis? Okay, so just 5 more seconds. Okay, so time to end the poll. I will be coming to the discussion of the results in the talk. On to the second question. So supracondylar humeral process can be differentiated from chondroma by. Okay, so just 5 more seconds. Then we'll be closing the poll and going on to the talk by Dr. Wasim. Okay, so time to end the poll. We'll be coming to the results of this poll at the end of our talk. Okay, so Dr. Meena, please start the pre-recorded lecture.
Bismillah ar-Rahman ar-Rahim. So today my topic of presentation is pediatric variants, which is commonly seen in musculoskeletal imaging. So to differentiate normal variants which may mimic pathologies, we have to differentiate through anatomy. And if you know the anatomy, you know that this is the location of epiphysis and the synchondrosis. Synchondrosis is basically the joint between the, it's a cartilaginous joint between the two flat bones. So if you know that this is the anatomical site of this synchondrosis or the epiphysis, you can differentiate it from pathology like fractures or any other things. So if you know the anatomy, you can easily differentiate. If you are not still sure, then clinical history is obviously important. Clinical history means if there is history of trauma, swelling, redness, or fever, then you can correlate with the findings seen on the X-ray or imaging. If still clinical history is not very useful and if you are not sure, then obviously you can ask for the contralateral site imaging. Thanks God that pathologies usually are not symmetrical. So if there is a normal thing or normal variant, it is present on the contralateral side as well. If this contralateral side imaging is not helpful, then you can ask for further imaging like higher modalities, for example, CT scan, bone scan, or even MRI. If the thing is still not sure on further imaging, the last thing you can ask for the follow-up. In follow-up, usually pathologies are resolved or may increase. But if this is a normal variant, it should persist without any change on follow-up imaging. So starting from anatomy, clinical history, contralateral side imaging, and further imaging like CT scan or MR or even follow-up, you can easily differentiate it's a normal thing or it's abnormal. So this is the X-ray skull of an infant and showing the cervical spine. This is the commonest. A, B, and C is the basically the cartilaginous joints and chondrosis of the sphenoid bone, and in the D is the basically D and E is the synchondrosis in the cervical spine. So these are normal joints which fuse in the later in the life. So it should not be confused with the fractures because these are normally present in the early stages and disappear when the skeleton is fused. This is the X-ray lateral view of the cervical spine of young child, and if you look carefully that C2 is slightly anteriorly subluxed in relation to C3, and this is common in the pediatric population because the laxity of muscles and the ligaments, and it is called pseudo subluxation. It's not a true subluxation, and it is also not associated with any fracture or soft tissue swelling. But in adult patients, this might be a true subluxation. So you should be careful while interpreting the cervical spine of the young patient. So this is pseudo subluxation. To differentiate it from true subluxation, you can draw a line which can be start from the anterior margin of the C1 to the ring of the anterior margin of the C1 to the posterior margin of the vertebral body of the C3. If the C2 body is more than 2 millimeter anterior to that line is true subluxation. So in this case, this is a normal pseudo subluxation of the C2 in relation to C3, which is normally seen in pediatric patients. These are the two views of the X-ray shoulder joint of a young patient, and you can easily identify the synchondrosis or the epiphyseal line and growth line of the proximal humeri, and it is very well defined, and if you look carefully there is some sclerosis as well. So this is a normal variant and it's not a fracture, and no soft tissue swelling is present or even the articulation between the glenoid and the humeral head is intact. So this is a normal thing, not a fracture or dislocation. This is the X-ray wrist AP projection of the young patient, and you can see that there is some partial fusion of the proximal epiphysis of the second metacarpal, and it is a normal variant and should not be confused with the fracture. So the usually this proximal epiphysis of the second metacarpal is fused early in relation to other parts, and there is no periosteal erection and no soft tissue swelling. So this is a normal partially fused epiphysis of the second metacarpal, not a fracture or healing fracture. This is the X-ray lateral view of the foot of the young patient, mainly focusing on the calcaneum. And you can see that the epiphysis is showing multiple fragments and some sclerosis, and it's a normal finding and should not be confused with the avascular necrosis or the fracture of the apophysis of the calcaneum. And you can also see that there is no soft tissue swelling and no periosteal reaction. So multiple fragments can be seen in the epiphysis of the calcaneum, which is a normal variant in this age group. This X-ray of the knee joint and the skyline view is focusing on the patella, which is showing bipartite patella, and the margins are somehow smooth and some haziness with no soft tissue swelling or periosteal erection, and this is a normal finding. So bipartite patella is present, and this is not a fracture or healing fracture. So bipartite patella can also be seen in this age group, and it's a normal variant. This slide is showing the X-ray pelvis and the hip joint of the young patient, and you can see that there is asymmetric, prominent, ill-defined sclerotic area involving the ischiopubic joint, which is ischiopubic synchondrosis, and it should not be confused with the infection or neoplastic lesion, and it is normally seen on the left side, and it may be asymmetric, and there is no periosteal erection or soft tissue swelling. And you can also correlate it with the clinical history, and if you are not sure, obviously follow-up might be helpful. So this is a normal ischiopubic synchondrosis, which is a normal variant in young pediatric patients. This is the X-ray of the pelvis and both femori of neonate, and there is increased echogenicity or the density of the bones, which is a normal finding in neonates because of estrogen effects of the mother, and it is usually resolved within 2 to 3 weeks. So it should not be confused with osteopetrosis, and osteopetrosis having some specific clinical features and clinical findings like hepatosplenomegaly and other things, and it is a bone within bone appearance, and this osteosclerosis of the newborn is a normal findings and can be seen in the early weeks of the life, and it's a normal variant. This X-ray is also of a young infant of the pelvis and the both proximal femur, and you can see that there is a smooth bilateral symmetrical periosteal erection, and it is a normal finding, and it appears to be a physiological in the newborns, and it is present early or the first 6 months of life, and it should not be confused with some pathology. And after 6 months, this smooth periosteal erection is resolved, and this physiological periosteal erection can be seen in along the long bones, especially the femur, humerus, and tibia. And there is no associated fracture or focal abnormality or soft tissue swelling. So this is a normal physiological periosteal newborn formation, and it is seen in the early or the first 6 months of life. This is the X-ray of the both knee joints, frontal projection of a young patient, and there is increased density of the metaphyseal ends of the long bones involving the both tibia, femur, and the fibula. And dense metaphyseal line should not be confused with the metabolic abnormalities like lead poisoning, and it is seen in the young patients. And if there are 2 points in which you can differentiate it from metabolic abnormality. In metabolic abnormality like uh, lead poisoning, the fibular ends, yani, it means the metaphyseal ends of the fibula is also involved, while in the normal variant or the normal physiological dense metaphyseal lines are seen only in the tibia and the femur and usually not involve the fibular ends. Secondly, if there is some poisoning or metabolic abnormality, then this density is usually more than the cortex, the thickness or the density of the cortex of the long bones. So, dense metaphyseal lines in the ends of the long bones is a normal variant in pediatric population. This is the X-ray lateral view of the femur, and there is some cortical irregularity in the posterior aspect which is called evulsive cortical irregularity, and it is a normal finding, especially the young physically active males, and it is usually seen up to the age of 15 years, and it is resolved with later in the life, and it should not be confused with the some tumor or any other abnormality, and there is no associated soft tissue swelling or periosteal reaction. So this evulsive cortical irregularity is commonly seen in the young physically active males, which is a normal variant. This slide is showing the X-ray lower lumbar and the sacral area lateral view, and there is a well corticated density anterior to the sacrum, and this is a normal limbus vertebrae which is commonly seen in the lower lumbar and the sacral area, and it is a normal finding and should not be confused with the fracture or any other abnormality. So there is no periosteal reaction, and it is appears to be a well corticated and no soft tissue swelling is present. So this is a limbus vertebrae which is a normal variant. This lumbar lateral view X-ray is showing a lucent area in the posterior aspect of the lumbar vertebrae, which appears to be a spondylolysis, which is again a normal finding in this pediatric age group and can be seen normally. And there is no associated spondylolisthesis or focal abnormality, and usually this is a incidental finding. So spondylolysis in the especially in the lumbar, and second most common area is the cervical spine, which is a normal variant in pediatric population. And there is no associated previous history of trauma or any other thing, and there is no complaint of pain or clinical symptoms. So normally spondylolysis can also be seen in this age group. This is the axial view CT scan of the pelvis of the young patient and showing a well-defined sclerotic area in the right pelvic bone involving the ilium. So this is a normal bony island which can be incidentally seen on the CT scan or even on X-rays. So it should not be confused with the metastasis because metastases in this age group are rare, and it is metastases are usually multiple, and there is some abnormalities addition to this sclerosis. There should be some periosteal erections, soft tissue swelling, or even cortical break can also be seen. So focal bony islands could be incidental finding and can be seen in the young patients as well. and it appears to be a normal variant. This is the X-ray pelvis, mainly focusing on the both hip joints of young patient, and you can see that there is some asymmetry and relatively smaller left femoral head, which is again a normal finding. If there is, it can be associated with the developmental dysplasia of the hip, but in this case, there is only the relatively smaller left femoral head, and the femoral heads are well placed within the acetabulum, and there is no other additional or associated findings to suggest DDH. So, relatively smaller epiphyseal growth retardation can also be seen normally, and it can also seen in the Down syndrome as well. And if there is some infection or other abnormality, then acetabulum and the proximal part of the femur should also be involved, and there should be some soft tissue swelling. So isolated, relatively smaller asymmetric femoral head retardation can also be seen in young patients, and it is a normal variation or normal variant. This is the X-ray proximal tibia and fibula, and you see some linear bands of increased density in the metaphysis of the tibia and somehow in the fibula as well. So these are normal growth lines, can be seen in young patients because of excessive mineralization and excessive growth of the long bones. So it should not be confused or should not be labeled as some metabolic or lead poisoning. As we discussed in the previous slide or previous case, that lead poisoning is seen with increased dense metaphyseal band of the tibia and fibula and the all long bones. So these normal linear smooth variable size bands of increased densities can be seen in the metaphysis of the long bones, which is a normal variant in this pediatric patient age group. This is the X-ray knee, AP, and lateral view of young patient, and there is some linear, ill-defined cortical irregularity involving the distal metaphyseal end of the femur, and it is normal findings, and it can be seen up to the age of 12 to 20 years, and it is commonly seen in the males, and it should not be confused with the pathology, and it disappears when the skeleton is fused, and there is no periosteal erection or soft tissue swelling. So distal femoral cortical irregularity is also a normal variant and can be seen in the pediatric age group patients, or it could be an incidental finding. This slide is showing X-ray lateral view of the knee, mainly focusing on the proximal tibia, and you see some irregularity of the tibial tuberosity, which is again a normal variant, and it should not be confused with the Evergen fracture or the Osgood-Schlatter disease. In Evergen fracture, there should be some associated or adjacent soft tissue swelling with buckling of this cordyceps tendon. In this case, the tendon is normal, no soft tissue swelling, but there is some irregularity of the tibial tuberosity is present, and which is a normal finding in this age group. This is the X-ray showing AP and lateral views of the ankle and the proximal foot, and there are multiple well-defined calcific densities, which are accessory bones or sesamoid bones, and these are normal variants and can be seen in the hand and foot. And this is the ospironium, which is present in the tendon of the peroneus longus, and it is a normal finding, and it has a well corticated and well defined margins and no soft tissue swelling. So accessory bones can be seen normally and in the foot and the bones. And if you know the anatomy, you can easily identify these sesamoid bones. These are the x-rays of the foot showing the accessory or sesamoid bones of the medial cuneiform and the navicular bone, and they have very well defined margins, no soft tissue swelling, and well corticated. So these are the normal variants of accessory or the sesamoid bones, and no soft tissue swelling and no periosteal erection. So should not be confused with the fracture. This is the X-ray frontal projection of the foot, and you see that navicular is showing multiple fragments. So this is again a normal variant and should not be confused with any other pathology. So in the foot, navicular bone having multiple fragments, and there is no soft tissue swelling or any other abnormality, and usually patient don't have any clinical symptoms or history of trauma. So these are normal fragmented multiple fragments of the navicular bone, which can be a normal variant in this age group. These are the x-rays of the foot, which is mainly focusing on the proximal end of the fifth metatarsal, which is showing a normal epiphysis of the base, and there is no soft tissue swelling. And if you see that the long axis of this epiphysis is along the long axis of the fifth metatarsal, which is a normal variant. And if there is a fracture, the fracture is usually horizontal to the long axis, and there should be some associated soft tissue swelling. So don't confuse, and this is a normal fifth metatarsal epiphysis of the base of the fifth metatarsal, and it is showing the axis is along the long bone, and it's a normal variant. This is the X-ray of the humerus, which is showing a well-defined bony outgrowth, which is directing towards the joint, and it is a normal variant, which is called supracondylar humeral process. It is not osteochondroma. Osteochondroma is away. The direction of the osteochondroma is away from the humerus, which is shown with this diagram. This slide is showing the question which was given to you or presented in the initial of this presentation. So let's discuss the answer of this. So question was, when in doubt, how to differentiate fracture from synchondrosis? The option A is size of abnormality. So size is not very helpful. And duration of symptoms might be helpful, but the best answer is could be the contralateral comparison. So the answer is contralateral comparison. If you are in doubt and you are not sure, then ask for the contralateral side. If it is present on both sides, so it's a normal finding and it is not or unlikely to be a fracture. This is again a second question, and the question was supracondylar humeral process can be differentiated from chondroma by option is appearance. Appearance of the both can be seen. Location is not very helpful. Periosteal erection is not diagnostic. Direction is important. When the bony outgrowth is directing towards the joint, it is a normal variant of supracondylar humeral process, and chondroma is directed away from the joint. So answer is D, and density is almost same in the both cases. So chondroma is directing away from the joint and supracondylar humeral process directed towards the joint. So I hope after this presentation you must be familiar with the normal variants of musculoskeletal imaging in pediatric population, and you should be able to differentiate normal from abnormal to avoid unnecessary treatment or imaging. So the take home is, if you're not sure, ask for the contralateral, and if you're still not sure, then think of some other modalities, evaluation or follow-up or clinical history. Thank you.
Thank you very much. What we do is we ask for the comparison.
Dr. Wasim, can you just आपके पीछे बहुत सारा background noise.
Okay. So I hope now my sound is clear.
Yes, sir, you're audible.
So for severe disease, what I do is I ask for the contralateral comparison. If contralateral comparison shows that there is asymmetry and fragmented and sclerosis of the apophysis, then obviously this is a severe disease. If still not sure, I ask for MRI. MRI shows the joint effusion as well as the soft tissue edema and abnormal signals in the apophysis. So I hope this will give you the clear answer about the. But normally you see the apophysis of the calcaneum appears to be somehow fragmented and sclerosis, but there is no soft tissue swelling.
So, Dr. Wasim, we also have another question, that how to differentiate with calcaneal epiphysitis, asked by Hasib.
Yeah, the same thing is ask for the comparison. If comparison on the left side can differentiate, it's a pathology if asymmetry is present. If not, then obviously MRI is help. MRI shows the abnormal signals and the joint effusion and soft tissue abnormality. So basically, the
Okay.
differences are two: severe disease, avascular necrosis, and the inflammation. So inflammation you can see on MRI, effusion, and other things, and even avascular necrosis, because the avascular necrosis is also tended to trauma. So maybe you can see the things like inflammation and other things. And obviously,
Okay, so we have another question. Osteosclerosis of newborn should not be considered till which age of the child? Any cutoff of weeks after birth?
usually
So,
the
Dr.
hormonal.
Nader,
Yeah, this is I think for me because I shows
this,
the newborn. So basically, this is because of hormonal effect of the mother is mainly the estrogen. So usually the estrogen effects or the mother hormonal effects resolve within months. So the neonatal age, after the neonatal age, it is considered to be abnormal if there is increased density. Otherwise, these are usually up to the 6 weeks of life. It may present at 6 weeks. I hope.
okay, so we have another question. To repeat the difference between lead poisoning and dense metaphyseal line by Fatma.
Okay, so basically there are two features on which you can differentiate. For lead poisoning, the fibular ends are involved, but in not the fibular ends are usually not involved. One thing. Secondly, the dense metaphyseal lines are more denser than the cortex of the long bones in abnormal lead poisoning. But in normal variant, the metaphyseal lines are dense, but not as much than the cortex of the long bones, the thickness and the density of the cortex of the long bones.
Okay, right. So another question by Akila. How to differentiate small femoral epiphysis from Perthes disease?
So in the Perthes disease, basically it's unlikely to be present in the early ages of life. It is usually in the active, physically active age, one thing. Secondly, in avascular necrosis, the in the follow-up or even the X-rays, there is more sclerosis and atrophy of the femoral heads. But I'm talking about the early ages of the small asymmetric apophysis, the femoral heads, which is a normal finding. In this case, in that case, the femoral heads, apophysis might be small, but they are not sclerosis, irregular, or any other thing, or any soft tissue swelling, or even there is no history of trauma or any other thing, yeah, even disease. Still, if you are not sure, then obviously follow-up images might be helpful. In which, if there is avascular necrosis, then obviously the the consequences of the disease can be seen, and if it may be bilateral or in both sides of the hip joint. So, in conclusion, in early stages of life, it should not be confused with the DDH or any other thing. So, small femoral epiphysis might be a normal variant.
Okay, right. So, Dr. Nadir, would you like to add something to the questions that we have just discussed?
No, all right, thank you.
Okay, right. So we have another question that what are the typical locations of physiological evulsive cortical irregularity by Nida Rove?
So basically, evulsive cortical irregularity most commonly seen in the distal femoral area, but it can be seen in the other long bones ends, but most commonly seen in the
Okay, so I think we have some connectivity issue at the moment. Dr. Nadir, can I refer this question to you? That what are the typical locations of physiological evulsive cortical irregularity?
So the most common I'm thinking right now is the knee. That we see that quite often. Are you talking about like the evulsive injury, cortical evulsive injury? Was that the question?
yeah,
Yes, physiological evulsive cortical irregularity.
Yeah,
most commonly
yeah, right. What we saying. I don't think we can hear him.
I think
Uh,
now that you can take this question. Dr. Wasim has the
yeah.
connectivity. I think you can,
So I
and
think
then I have questions for you as
yeah,
well.
I mean in the knee, in the posterior medial wall, you get that it's called cortical desmoid, which is actually not a proper name for it, but it is known by that name, where you get quite common. I think the gastrocnemius muscle, the medial gastrocnemius muscle, that causes very common in children, adolescent children who are very active. And sometimes on a frontal X-ray, it looks like a lucent lesion. Many times, orthopedic surgeons have come asking for MRI for that, and we just reassure them that this is just a lucent lesion, very commonly seen, and just do a follow-up X-ray in 6 weeks, just to reassure the parent that this is just a cortical desmoid. Other evulsive injuries occur around the patella, inferior to the patella, where you get Sunding-Larsen's disease and the superior patellar ligament, inferior patellar ligament, you get Osgood-Schlatter disease. And these are the more of the chronic evulsive injuries that I can think of.
Okay, right. So Dr. Kiran, would you like to ask a question from Dr. Nadir?
Yeah, I think there are the lots of questions for Dr. Wasim because he talked about the lots of variants. So, but Nadir, I was just wondering that what protocol do you use in your hospital university? Because when you are suspecting the osteomyelitis, especially in the child who is less than 2 years of age or a child who is having the less than 5 years of age, what is the protocol in terms of covering the lengthways? You know, the most of the time the osteomyelitis is, I mean, either it's a
Yeah,
hip or it's a knee or it's a foot, you know that. So because of this more circulation and the pooling of the blood. So is there any particular protocol in your setup, for example, for the neonate? What extent of the limb that you cover whenever you're
yeah,
suspecting the osteomyelitis? And the
so,
other question to you, I mean, I'm sorry, I just asked the two questions, you can
yeah.
answer them at once. So, my other question is this the MRI that you have, or do you go for the other nuclear scanning whenever, especially for the infection, or you go for the PET? So, do you do that, or you just rely on the PET MRI scan?
Yeah, so for the second answer, for the second question is that yes, just MRI. I mean, obviously we always get radiographs, but like I said, They hardly, if you think about infection and the X-ray is normal, it doesn't mean anything. You do it, you still do the X-rays because you need the X-rays, but they're very not very helpful as far as infection is concerned. But yeah, it's always MRI. And then a lot depends upon what age of the patient is. So we have a protocol where between 6 months and 5 years, we only do GA. Below 6 months, we can do feed and wrap, and above 5 years, we go with normal scanning without anesthesia, unless patients got autism or some other problem. And so that's number one, where we divide under GA and under sedation, under feed and wrap. And the second thing is that where we just, so if we know where the specific joint is involved, that we know the right knee is swollen, then we'll do specific sequences for that joint. And it's mainly predominantly STIRs and T1s and in different planes. And sometimes we add contrast with T1 FATSAT. But many children who come in less than 3 to 4 years old, they cannot explain, and sometimes you don't know whether there's no swelling. There's nothing obvious. They're tender all over their leg, and sometimes it's so confusing. They won't put both their feet down. They'll stop walking and they limp on both feet. So it's very difficult with them, with the younger children. So in those cases, and they're all done under GA usually, they're less than 5. So we start from the pelvis. We start doing big field of view, coronal, STIR, and T1s, and then we'll do the pelvis first, and we'll try to cover most of the femur, and then we'll do the knees, and then we'll cover most of the femur and the tibia, and then we'll do the ankles, sagittal ankles, and we'll try to cover as much of the tibia. So in 3 sequences, we get the whole leg. And then once we see where the problem is, we'll do some axial sequences through that area, and then we'll do post-contrast if needed. And that's how we go about depending what age of the patient is, and if we know is a specific area that we're targeting, or we're not too sure, we just start scanning from the pelvis down.
Thank you very much. So just in the continuation of the same, so do you go, so when you say the large field of view, so you mean that sometimes you go for the
source of infection is, but I assume we could do a bone scan, an MRI, and if you're looking for a source of infection, but usually I think we can target the limb at least, if it's upper limb or lower limb, and then we'll do a big field of view scans through that limb. And once we find where the problem is, then we target that area. But can't remember the last 6-7 years if I've had this patient where we did not know where the source of infection was, and we did a whole body MRI. We haven't, done that yet.
Thank you.
So we have another question that from an anonymous attendee, that septic arthritis develops into osteomyelitis. How do we follow either MRI only, or what else protocol to follow in such a case?
Yeah, I mean, the patient has to be not seen by somebody for a very long time for septic arthritis to become osteomyelitis, for it to erode the bone and get inside. I mean, the patient has not been treated, and I could see that happening in other countries. But it will be very difficult at some point to be sure. Most of the time, osteomyelitis may have some infection in the joint. That's easier for it to happen. But septic arthritis, if it picks up really early, it doesn't always have osteomyelitis. You can have a bit of edema, you can have a bit of enhancement in the bone marrow, but unless we don't see a heterogeneous pattern and non-enhancing areas, our surgeons don't want to go in until we are certain that there is a abscess or a area of pus. They don't want to, because once they're going inside, there's a higher risk of infection. They could spread inside the bone marrow when it's not needed. So we have to be, it took me a while when I went to England. It took me a few years to understand this and how to go about helping them to decide when they have to go to the bone marrow or not. And really, they need to know there's an abscess, like a Brody's abscess or some well-defined abscess, or there's a non-enhancing irregular area on the post-contrast sequences, which tells them where they have to go and drain the pus.
Okay, sir. Sir, another interesting question in our Q&A, that is the use of CT in detecting osteomyelitis in the young, as it's less time consuming. So does it provide any clues?
No, I think that especially in our center, children are presenting really early. So in that case, CT for us is not useful. Obviously, if you have a patient who has got a very chronic infection and you're looking at dead bone and all those kind of things, it might be helpful. But we tend to see them really early on. The X-ray is always almost normal. So when the X-ray is normal, the CT is not going to add too much. I think that X-ray are better than CT scan. X-ray gives you a lot more information, and you really don't need a CT. I mean, I showed a couple of CT scans, but those are cases where we were scratching our heads. We were not too sure what was going on, and so we basically did everything to figure out there was a leukemia patient and those things. With a leukemia patient, for example, when they did the bloods were normal because there was not enough time for the red blood cells to die out, for new red blood cells to form. Then the red blood cells will show normality. So the patient was presented so soon, and we did the scanning so quickly that even the bloods were not abnormal in that leukemia lymphoma patient, and we already scanned them. So that's how quickly we're scanning patients who present with symptoms and diagnosing the underlying problem even before the bone marrow, the blood has shown any changes.
Right, sir. So one last question that has been repeated at least 2 times in our chat box. That is how to differentiate between AVN of the navicular and fragmented navicular bone, asked by Mehboob Ahmed and Kiran Shehzadi.
Is that for Dr. Mirza? Dr.
Yeah.
Wasim?
Yeah, again, I think the answer is MRI. If you're as the basic principle is, if you are clinically suspecting avascular necrosis, then first is the comparison of the X-ray with the contralateral calcaneum. If asymmetry is present, then think of this. If not, if you are not sure, then go for MRI, or even you can ask for the nuclear scan.
Right, sir. So one more question. How to differentiate between reactive arthritis and osteomyelitis?
Yeah. So I mean, reactive arthritis is going to be in the joint. So I mean, I suppose the question is that reactive arthritis and septic arthritis, and so yeah, between them, I don't think you can. Meaning that if the bloods are abnormal, obviously, then if there's enough time and the bloods are showing white cell count to be elevated, ESR, CRP is elevated, then the likelihood is, if the patient is also septic, the likelihood is it is septic arthritis. And septic arthritis tends to have more soft tissue changes as well, or bone marrow changes. But like I said, sometimes they present so early, and we're scanning them, you don't end up having those changes. I mean, the blood sometimes can be normal with septic arthritis, and so in those cases, that's why our surgeons, when we say there's a joint effusion, they go in and they aspirate, it has happened that they haven't gone in and they were quite sure it was reactive arthritis, but generally I would say 95% of the time they would go in, aspirate, and confirm that there's no infection in there. Because they can't depend upon bloods. But yeah, in a typical scenario, if you're a septic child with elevated inflammatory markers and there's joint effusion, it's likely to be septic arthritis.
Okay, right, sir. So with that, I would like to thank our guest speakers, Dr. Nader and Dr. Wasim, for enlightening us with their experience regarding pediatric musculoskeletal imaging. I'm sure this would enable our audience to not only better appreciate normal variants from pathologies, but also ensure not to miss an emergent finding in a musculoskeletal case. Thank you all for joining us and enabling our second webinar broadcast to be a massive success. So just one more thing, and do not forget to join us on 18th of January for our next talk that is scheduled to be on cardiovascular and chest imaging by Dr. Naila Nadeem and Dr. Maria Hamid. So inshallah, see you all next week. Thank you and goodbye, everybody.